Chosen this topic because there's very little known about why recurrent pregnancy loss happens, and often these couples are very anxious to understand, and we also want, as doctors, really want to help them and see where we can find an answer for them. So, is my screen visible?
Yes, Dr.
Okay.
Kanika.
Yes.
Okay. So, recurrent pregnancy loss is now defined as two or more consecutive pregnancy losses by the American Society of Reproductive Medicine and the ESHRE guidelines as well. So, we like to understand if it is broadly, it is happening in the first trimester or the second trimester, because the causes can be different. And about 15 to 20% pregnancies end in spontaneous abortion. So, recurrent pregnancy loss, especially in the first trimester, so it affects about 1% of the couples, and in about 20-30%, the cause can be genetic, but there can be so many other causes as well. So, that this yield is like if other causes are excluded. So, if we look at this diagram, so 2 to 5% are genetic causes, 10 to 15% are anatomical, 20% autoimmune, 0.5 to 5% infections, 17 to 20% can be endocrine factors, and despite extensive workup, 40 to 50% may remain unexplained. So I'll move first to the genetic causes. So the fetus may have some genetic abnormalities. So this tendency is more if it is in the first trimester. About 50% of first trimester pregnancy losses can have chromosomal abnormality in the embryo, which could be aneuploidy, which is basically the abnormality in the number of chromosomes. It could be something more complex chromosomal abnormality, or mosaicism. So, if we look at some data, then trisomy 1622 are some of the most common causes of fetal aneuploidy seen in tissue of recurrent pregnancy loss. Sometimes it is monosomy X. So here we can see a karyotype which is showing that there are three copies of chromosome 13. So this is basically an aneuploidy or a trisomy. But there could be others. There could be triploidy, which is basically all the chromosomes are in three copies, and more complex chromosomal abnormalities. So, as I said, it could be fetal chromosomal abnormality. So, basically, earlier the loss, the higher is the chance of chromosomal abnormality. It can be up to 50 to 90% in the first trimester. But whereas if we go into the second trimester, the only 6 to 12% of stillbirths are associated with chromosomal abnormalities, although we still check for it. So whenever taking a history for a recurrent pregnancy loss, it is very important to understand, is it happening in the first trimester or the second trimester? So when I talk about chromosomal abnormalities, yes, there is a little age effect that women who are above 35 years and male above more than 40 years have a more tendency to have either egg or sperm in their body, which carry an abnormal number of chromosomes. And somehow it has been seen that it is twice as likely to occur in the mother as compared to the father. So, some individuals, about 1 in 600 individuals in the general population, have a thing which is known as a balanced translocation, which basically means that if we can see in this diagram here, that basically in the cell, all the chromosomes are present, but there is an interchange between two chromosomes. So, that individual themselves, they are going to be normal, they are not going to have any problem. But when the gametes are made in the body, the egg or the sperm, we can see that in during the meiosis, the chromosomes have to come together and then finally separate. So it can lead to some both type of gamete. There can be egg or sperm carrying normal chromosomes as well as abnormal. So this affects about 7% couples with recurrent pregnancy loss, especially if it is in the first trimester. In this diagram, it is basically showing in the number 1, there can be normal gametes, either balanced or normal, whereas if the separation occurs in the adjacent manner, then they can have unbalanced gametes. So basically, if this interchange between two chromosomes is between the chromosome 13, 14, 15 or 21 to 21, 22 and Y, it is a Robertsonian translocation because these chromosomes don't have a P arm. So normally chromosomes have a P arm and a Q arm, but these are the chromosomes which don't have a P arm. So 13 and 14 Robertsonian translocation actually is quite common in the general population. And these couples can also go on to have normal children. About 50 to 70% can have normal children. But it can also result in recurrent pregnancy loss. Sometimes it may not result in a pregnancy loss, but we may see pregnancy being recurrently affected by some birth defect or recurrent ultrasound abnormalities. So the counseling for a translocation carrier is that although they themselves do not have any illness, they can have unbalanced gametes. And actually, the risk will vary from which chromosome is involved. But broadly, there is a 70% chance that they can have a normal child and about 30% chance that either it can keep having a recurrent pregnancy loss or they can have a child with a disability or a birth defect. So the first step is actually to identify these couples, and then we can discuss the different options with them. That is, they could go for a normal conception. There is like 70% chance that pregnancy may continue beyond the first trimester into the second trimester, at which point we need to confirm that the baby has got normal chromosomes by a prenatal diagnosis, so that we don't have a baby who has a birth defect or has an intellectual disability, because we know a lot of times these are just manageable, not curable. They could go for a pregnancy with a donor gamete, like depending on from which partner the chromosomal abnormality is coming, ovum or sperm. Now we do have IVF with pre-implantation genetic diagnosis, where we can check the embryos for these chromosomal abnormalities, and finally they could go for adoption. So there is only one chromosomal abnormality, 21, where there is 100% risk of recurrence. Again and again, the baby will keep having trisomy 21. So for these couples, they cannot, prenatal diagnosis or PGT is not a good option. They will need to go for a donor. Sometimes the recurrent pregnancy loss can be associated with the genes. So now we all are familiar that our body is made of small cells, and in the cells are the chromosomes, and inside the chromosomes are the genes. So most commonly in the first trimester, I said it is the chromosomes which are the cause of recurrent pregnancy loss. But in second trimester, especially, it could also be a genetic condition, especially if there is some abnormality which is coming up on the ultrasound again and again. For example, fetal arthrogryposis, where the baby is not moving well. There could be polyamnios or recurrent hydrops. There's swelling in the baby. So, or there are some other ultrasound abnormalities, kidney anomalies, or short, long bones, which are coming up again and again. And sometimes in sudden cardiac death, it has been seen that it could be long QT syndrome in the baby or a stillbirth. So this, as I'll be showing in the next slide, this will depend on whether this is an autosomal recessive, X-linked, or autosomal dominant condition. Now we do know that there are some females who are themselves homozygous or compound heterozygous for genes related to oocyte or embryo implantation failure. So these women are also likely to have recurrent pregnancy loss. So I showed the picture about chromosomes. So genes are basically, we get all genes in two copies from our parents, and when we pass them on to children, one copy goes from the mother, one from the father. So autosomal dominant are when single copy of the gene is affected and still the person can have a disease. So if it is inherited from the parent, they will have the disease themselves, but many times it can be a new mutation. It is not necessary that all genetic are always inherited from parents. It could be a new mutation. Autosomal recessive are when both the gene copies are abnormal and then the baby is having the disease. So like Varun was speaking about sickle cell disease, we know sickle cell is an autosomal recessive condition. The parents are carriers. They are not going to be affected. They will be mildly affected. Or sometimes or not affected. But if both the copies are abnormal in the child, which is a 25% chance, then the child can have the abnormality. X-linked conditions tend to present more in the males because they have a single X chromosome, whereas females have two X chromosomes. And there are some now variations which are normal in the population. So when many times when we do a karyotype of both the husband and the wife, there are some things which are called as polymorphic variants, especially on the chromosome 1, 9, 16. It may be sometimes written as QH. So the QH basically stands for increase in heterochromatin region. So what is this heterochromatin region? Basically, it is the increase in the part of the DNA which is full of repeats. So it does not have much genes in it. That is why it is very well known and studied in science that these are not the cause of recurrent pregnancy loss. They can be seen in a lot of people in the normal population. And inversion of the Y chromosome also, it may be seen in many males, but there are now both type of studies. Some studies say that it may be, but then the consensus is more that this is not a cause of recurrent pregnancy loss. So now I'll talk a little about the non-genetic causes of recurrent pregnancy loss, because there are so many wide causes of recurrent pregnancy loss, and we have to sometimes extensively evaluate the couples, and it is not enough that only if we think about the genetic causes. So now if we move to the anatomical causes, then uterine septum is one of the cause which is given as a known cause for recurrent pregnancy loss or some Mullerian abnormalities. So role of arcuate uterus is unclear. Sometimes there may be intrauterine adhesions or uterine fibroids, but usually large size fibroids or polyps, then they can also sometimes cause recurrent pregnancy loss. The cause may be that it interrupts the vasculature or the placentation of the embryo. Then in the second trimester, we know it can be cervical incompetence, especially if there is a history, like there is a recurrent spontaneous rupture of membranes into second trimester. The ultrasounds are completely normal. There's a bulging of membranes through the cervix, or there's painless cervical dilatation. Then there is a chance that it could be cervical incompetence, for which usually the cervical encerclage is suggested, and this is usually diagnosed by the typical history which is there. So cervical surveillance is started in these patients at 14 to 16 weeks, which means that you have to keep seeing with the ultrasound the cervical length, and consider cerclage if it is less than 25 mm before 24 weeks. Then the endocrine causes of recurrent pregnancy loss. So earlier they used to talk about the luteal phase defect and used to consider evaluation for it and give progesterone supplements. But now it is no longer considered for evaluation, although on case-to-case basis you may consider giving progesterone supplements. But now from guidelines, actually they have removed this. Polycystic ovarian syndrome causes not only infertility, but it also causes recurrent pregnancy loss because of the poor oocyte quality. Uncontrolled diabetes can result in in recurrent pregnancy loss. So having a good diabetic control is important, and uncontrolled diabetes can also lead to birth defects in the baby. Untreated thyroid disease and hyperprolactinemia, especially if there is a history of galactoria, that is milk from the breast, and anovulation or infertility, anovulatory cycles or prolonged cycles. Then in coming to the infectious etiology, so this is a little less common, and generally it is not taken as a cause of recurrent pregnancy loss, especially the torch infections, that is the toxo, rubella, CMV, etc. Because most of these are the viral infections which give immunity, and they generally are not considered a cause for recurrent pregnancy loss, but it can cause abnormality in one particular pregnancy, especially if you are suspecting if there is IUGR, or there is the ultrasound in the baby showing ventriculomegaly or calcification, then one can think that it could be torch, and the outcome is usually not good, but generally it does not cause pregnancy loss again and again. And also, if the IgG is positive and IgM is negative, then it is generally indicates the immune status for the female. Then now coming to thrombophilia. So there are two thrombophilias. One is the heritable, which are basically the genetic ones. which can be because of the factor 5 laden mutation, protein C, protein S deficiency, prothrombin mutation, antithrombin mutation, or it could be the acquired ones, which are basically not having a genetic basis but a autoimmune basis, such as the antiphospholipid antibody syndrome. So the antiphospholipid antibody syndrome, it has a clinical criteria before we can label that it is because of antiphospholipid antibody. So sometimes these are the clinical criteria. So we need one clinical and one lab criteria. Clinical criteria is that the lady may have history of some vascular thrombosis or deep vein thrombosis or some event like that in her body, or she may have 3 or more unexplained pregnancy loss, especially less than 10 weeks, 1 or more greater than 10 weeks, or 1 preterm birth. For the lab criteria, we test 3 antibodies. They are the anticardiolipin, lupus, and beta-2 glycoprotein, both IgM and IgG, and they should have significantly raised levels, more than 99th percentile. And this test should be positive at least 2 times, 12 weeks apart. So it is also important that this evaluation is done at least 6 weeks after the pregnancy loss has occurred, because it is believed that once pregnancy loss has occurred, there is a lot of change in the physiology of the body, and sometimes they can be false positive. So we should wait at least 6 weeks after the pregnancy loss has happened, and after that we should test them and confirm that it is positive at least 2 times, 12 weeks apart. So now coming to the immunological factors. So basically this is a very debatable factor, with lot of studies saying that yes, there is an immune mechanism involved in rejection of the embryo, and some studies saying that there is not enough data, and actually guidelines say that these should neither be evaluated for and nor be treated. So basically there's a concept that in a normal pregnancy, the embryo is foreign to the mother, because of which there are some protective antibodies which are formed, which prevent the rejection of the fetus. But in some women, this protective antibodies are not formed, and there is a hyperimmune state, which can be sometimes indicated by high levels of TNF alpha, NK cells, which lead to abortion of the fetus. So in, like I said, that in normal pregnancy, there's an immunomodulation, because of which the NK cells go down, and there's a shift to in the immune response, which leads to protection of the embryo. So some studies also say that if there is HLA sharing between the partners, which is HLA is also the marker on the chromosomes, that then there is less of these protective antibodies, because of which there can be rejection of the fetus. So earlier we used to do HLA testing. Now we don't do it that frequently. But yes, sometimes on case-to-case basis, we like to test for some increase in cytokines like TNF alpha or NK cells. Although studies say that they can be done in both in endometrium and blood, but sometimes due to feasibility, they are more often checked in blood, because most studies say that if they are increased, they are increased in blood as well. Then now coming to a newer terminology, which is the sperm DNA fragmentation. So basically, this is something which is now coming up in studies, and even both American Society of Reproductive Medicine, ESHRE guidelines, they give it some conditional approval. They don't say that it is completely useless or non-beneficial. So the theory behind this is that basically excessive DNA damage in the sperm can impair the embryo quality, halt the blastocyst development, and increase the risk of miscarriage. So there are tests to check for the sperm DNA fragmentation index, and generally more than 30% indicates a high level of damage. Anything below this may be acceptable. So the cause for this is usually multifactorial. It can be, it is generally thought to be some oxidative stress, men who have varicocele or other infections. So the individual, the male person may need a urology evaluation as well. Or if there is a lifestyle factor like smoking, obesity, and advanced age, then this can also lead to increase in sperm DNA fragmentation. So how do we evaluate a couple with recurrent pregnancy loss? Like I said, like in my mind, I like to broadly see, is it first trimester or second trimester? First trimester, genetic chromosomal must be ruled out, antiphospholipid antibody, endocrine causes in the lady, the uterine structure in the lady, and autoimmune causes. In the second trimester, we have to think of cervical incompetence, uterine adhesions, endometriosis or bacterial vaginosis. Congenital anomalies, uterine can also cause pregnancy loss in the second trimester. And if there is a recurrent ultrasound abnormality in the second trimester, then it is definitely some genetic cause, which can be related to the genes. So we need to know about a number of abortions when they are occurring. If the lady has any chronic illness, maybe she has SLE or she has alopecia or she has any other illness which could indicate that she has an autoimmune predisposition, their profession, if there is any malformation coming up in the ultrasound, if there is family history of infertility, recurrent pregnancy loss, or any child who has a developmental delay or a malformation in the family. Then the lifestyle factors, history of PCOD, diabetes, DVT in the lady. And generally, the prognosis depends on the number of pregnancy losses and female age. So usually after one pregnancy loss, the statistical chances are very high, 80 to 90%. So it decreases slightly with every pregnancy loss. But even after 3 pregnancy losses, the chances of having a successful pregnancy are quite high, 65 to 70%. So there is some testing that should be done in all patients with recurrent pregnancy loss. This is evaluating the chromosomes of the product of conception. So ideally, this is the best thing that we can do, but I will discuss in some situation we may not be able to do. So when the tissue, when the pregnancy loss happens, especially if some procedure is done to remove the tissue, then that tissue can be tested for a test known as chromosomal microarray. So earlier we were preferring karyotype test, but now it is shown that microarray has a higher yield because karyotype can pick only very big deletion, duplication, or missing or extra part of the chromosome, but microarray can pick up much more. So microarray should be done as the first test, and we should also send the mother sample along with the microarray when we are sending the mother sample, because the lab likes to check that we are actually checking the baby's DNA and not the mother's DNA, because sometimes there'll be so much mixing of tissue that we are just giving a normal report, the lab is giving a normal report, but it was just the mother's chromosomes which are checked. So when we send both the tissue plus the mother's blood sample, EDTA sample, then they will check for the maternal cell contamination and say that it is negative and this is really the baby's test. Then secondly, a uterine cavity evaluation. So this could be either a 3D ultrasound, it could be a hysterosalpingography, or nowadays even a saline ultrasound to see if there is any developmental anomaly of the uterus or fibroid or polyp or any such thing. Then antiphospholipid antibody syndrome. So the 3 antibodies which have to be checked are the beta-2 glycoprotein, anticardiolipin, and lupus anticoagulant, preferably 6 weeks after miscarriage. The hormonal causes, thyroid profile plus minus TPO antibodies. So actually TPO antibodies, it is not mandatory as per guidelines, but I like to do because it gives some idea that the lady may have some autoimmune predisposition. HbA1c for diabetes, fasting blood sugar, and of course because PCOD is now becoming so much prevalent in the population, then one must of course look for PCOD. So, and now coming to testing in selected patients with a recurrent pregnancy loss. So this testing you may consider not in all patients, but based on your first workup, if it has come normal, then you want to see what else it could be. So, like I said, if POC or the product of conception, the tissue testing is not of the fetus or the baby is not feasible or not possible, then you may want to do a couple karyotype. In couple, we don't do the microarray because due to the difference in the method of the test, the microarray cannot pick up the balanced translocation. which I had shown earlier in my previous slides. And in the parent, we are not looking for the abnormal chromosomes. We know that they are normal, so we are looking for the balanced translocation. So if POC testing is not feasible, could not be done, then we do the couple karyotype. Sperm DNA fragmentation, we are not doing it very frequently, but it can be considered, especially if there is setting of infertility also, and all the other workup is normal. Checking for chronic endometritis. So in guidelines, they talk about endometrial biopsy. Again, that is not done routinely, but depending on the history, you may want to treat for it or send a vaginal swab. Fasting prolactin is usually done as per guidelines. It is recommended only if there is a history of galactoria or anovulatory cycles in the lady. Checking for the other inherited thrombophilias, like not the anti-phospholipid antibody, the factor V laden, prothrombin, protein CS. So this is now removed from the guidelines as a cause of recurrent pregnancy loss. But then again, in case to case basis, if we are not finding anything else, or if there is a history of something like DVT in the lady, or more so in the second trimester, now it is seen that those studies which say that these are important, it is seen that it is more in the second trimester, then we may want to check for this as well. And finally, the autoimmune markers, like I said, the TNF alpha, CD19, which is basically the B cells, and NK cell, which is CD16 and 56. We do in the blood, especially especially if there is some clue for an autoimmune disease, or if the lady has some autoimmune history, or if all the other workup is normal, then and there are multiple pregnancy losses, then sometimes we do evaluate for this as well. So now coming to the management. So I have made this as a combination of ESHRE and ASRM guidelines. So if there is a genetic factor like a balanced translocation, then genetic counseling is very important. We motivate them that there is 70% chance of normal live birth. The options I told you before, they could try for normal pregnancy with a prenatal testing to see that baby does not have any disability, or they could go for IVF with PGT, or they could go for a donor. If antiphospholipid antibody syndrome is diagnosed or suspected, then low dose aspirin has to be started in preconception, and that is before they are planning the baby. From that time itself, and once the pregnancy is is positive, then prophylactic heparin has to be started. So levothyroxine, so a good thyroid control is very important. Lot of studies say that the TSH of the lady should be kept within less than 2.5. So we want a good control. The dose should be adjusted, that should be less than 2.5. And although most studies say that if there is no overt hypothyroidism, then but only TPO antibody are positive, then it should not be treated. And bromocriptine only if there is hyperprolactinemia. So cervical surveillance for if there's cervical insufficiency and cerclage. If there is any lifestyle factor, obesity, then it has to be corrected. And we know, especially in PCOD, diet and exercise has a very important role. And folic acid and multivitamins should be started, which are safe in pregnancy, early in pregnancy. You could consider, so this is recommended if you are suspecting PCOD, if there is PCOD or insulin resistance, then metformin has a beneficial role. If there are multiple fibroids, submucosal fibroids with a significant intramural component, then myomectomy is recommended. There is no conclusion for polyps, whether really they do cause a problem, they don't cause a problem, but as per guidelines, they say it is reasonable to offer hysteroscopic polypectomy if there is recurrent pregnancy loss and there are endometrial polyps. For intrauterine adhesions, then if there are mild to moderate adhesions, then hysteroscopic approach may be considered. So there is doubtful utility for procedures in which sperm selection is offered or good quality sperm is offered. So this is as per guidelines. Antioxidants for men who have, especially who have increased sperm DNA fragmentation index. So they say that we don't know if it really helps or not. For treatments like IVIG or intralipid therapy for women who have an autoimmune predisposition, but we do consider, especially if nothing else is found. And in my experience, it has helped a lot of women. Glucocorticoids generally we are not giving now, especially because there is increased risk of birth defects, especially cleft lip palate with glucocorticoids. And heparin or low dose aspirin, they say prophylactically, like if you have not found any thing, then there is doubtful utility. Although sometimes, again, on case to case basis, it may need to be given. So the prognosis depends on the underlying cause and the number of prior losses. So the chances of having a successful pregnancy, it does decrease after every loss. It does keep going down, but even after 3 to 4 losses, there is a good chance of a successful term pregnancy. Now, talking just a little bit about pre-implantation genetic testing. So basically, this is a procedure which is done on the embryo. The embryo is analyzed at the blastocyst stage most commonly for the genetic analysis. Now, I'll come to it. Now, there are 3 types of pre-implantation genetic testing which we can do, and basis of which we select the most appropriate embryo, and that is transferred to the uterus for carrying a pregnancy. So there are 3 categories of pre-implantation genetic testing. So there's PGT-A, which is basically chromosome number, recommended as routine in all IVF pregnancies, but it may be done if there is advanced maternal age, because like I shared with you, these women have a tendency to have more chromosomal abnormalities in the pregnancy, and we don't want that they go for an IVF and then it results in a miscarriage. If there is a severe male factor, or in some cases, if there are couples with normal karyotype, but there are recurrent miscarriage and they have gone for IVF. So we want to select the embryo which has the best potential for survival. Then PGT-M or monogenic. So this is done for a lot of single gene causes. So it can be done both for something like which is like hydrops or arthrogryposis, which is resulting in a recurrent pregnancy loss. Or it can also be done for the late onset condition like thalassemia, sickle cell anemia, and many other conditions. But all PGT, we have to confirm it by either by a prenatal test, either in the 3rd month or in the 5th month, because PGT is still not considered the gold standard or 100% correct. And then PGT-SR, which is more relevant right now in the setting of recurrent pregnancy loss. This is done for the couples who have the balanced translocation and there is a recurrent pregnancy loss. So normal embryo can be selected. And we do have PGT-HLA also, that sometimes if PGT is being done for some other condition, and if there is also like a thalassemia or sickle cell anemia, and the parents want to plan a child which may be matching the first child as a bone marrow transplant donor, then it is possible. There are some uh, it is definitely better than prenatal testing where we check for HLA and then that is ideally not correct, that we are checking and then deciding the fate of the baby based on which he's a potential donor for the sibling or not. But for PGT HLA, we can select the embryo which is both not affected as well as a suitable match for the first child. Thank you. I'm happy to take any questions.
Thanks, Dr. Kanika. So let's open the questions. Please feel free to type your questions or ask them directly to Dr. Kanika. Dr. Isaiah is a obstetrician and gynecologist. So
thank you so much, Dr. Kanika, for the wonderful presentation, and I'm very happy to participate during this session. I would like to know the procedures of sperm selection. How do you achieve, especially in my clinic, I meet several couples whose age has advanced. whether be a mother or a male over 50. In male over 50, what are the chances of getting the best sperm for implantation? One, how do you do the procedure of sperm selection? And the second, in those couples, in a married partner, what are the chances that they have the best sperm for implantation? Thank you.
Yes, so I will not be able to tell you about the procedure for sperm selection because in my hospital, usually this is a multidisciplinary thing. So usually the genetics, the IVF specialist, and multiple doctors are involved. So usually they are doing it in their lab. But yes, above the age of 50, there is a high chance that the sperm quality may be poor. Like what I talked about, the sperm DNA fragmentation index may be increased, so unless we test for it, we don't know. But even without doing the test, there is a high chance that some sperm may have poor DNA quality, which is resulting in a recurrent pregnancy loss or may
Thank
result
you
in
so much.
implantation failure.
Okay,
Yes.
Dr. Isaiah, as I understood from your questions, it has multiple parts about selection. Like Dr. Kanika can answer it from a medical genetist perspective, but like we have organized master classes on fertility, like IVF specialists, so we can direct a question to them, so that they can point you with the right guidance. Or if there is a specific patient that you want to consult, so you can get in touch with us and we'll help with that. We have a question from Dr. Egbogu Stanley. So, for patients with PCOS, how long is she supposed to take the metformin before conception and after conception?
So the metformin should be started at least 2 to 3 months before conception, and usually it is continued into the pregnancy. It is safe to take in pregnancy as well, but it has to be monitored by GTT as well as regular HbA1c and the blood sugars. So usually 2 to 3 months before conception.
Okay. So we have another Dr. Kanika John Claude. So she's from
Okay.
DRC. Oh, okay. So Dr. Kanika, as we have shared that message, that we will share both. We'll share the recording also with you so that you can follow it later, and we'll share the summaries also. We have noted down your email ID and any other questions that anybody else have. Yeah, Dr. Stanley, we have noted your email ID also. Any other questions that anybody else may have? So if we don't have any questions, we can conclude the session, Dr. Kanika, if you have your permission.
Yes, sure, okay.
Yeah. Before that, I wanted to thank you all